We find that if only 20% of cases are isolated starting May 24th and staying at that level through the next 90 days, we project a 65% chance of a large outbreak. But if 70% of cases are isolated, a large outbreak becomes much less likely, and there's only about a 1 in 20 chance of an outbreak with at least 10,000 cases.
I'm Eric, and this is Research Notes. In this episode, I talk with Lieutenant Commander Eric Mooring. He's an epidemiologist and a data scientist with the U.S. Centers for Disease Control and the U.S. Public Health Service Commission Court. In early June, Dr. Mooring and his colleagues published a paper in the MMWR that modeled how the Ebola outbreak in the DRC and Uganda might unfold. The model is what's called a branching process model. And in the episode, Dr. Mooring walks us through the model, especially the uncertainty in the model and why they're referring to this as a modeled scenario projection rather than a forecast. Now, the model shows there's a big difference in what might happen in the epidemic with 70% isolation versus 20% isolation. In addition to talking about the model itself, Dr. Mooring walks us through his career trajectory from an undergraduate to getting his doctorate of science in epidemiology and then going into public service. I hope you enjoy our conversation. We're talking on June 26th, and right now there are more than 1,100 cases across the DRC, Uganda, and I did see one case in France, and almost 300 deaths confirmed at this point. I want to go back in time, back to mid-May, when you have two health ministries declare outbreaks. There's a few hundred confirmed cases at that point. What's your team trying to figure out about the unfolding epidemic?
So back in mid-May, the number of laboratory confirmed cases and deaths was quite low, but the number of suspected cases and deaths was much higher, and that was really the concerning part of this situation. And our initial work focused on calibrating the model to the number of suspected deaths. And we were really trying to get insights into two questions. One was how many infections might have already occurred at that point? And second, how far back in time might the outbreak have started? From the beginning, we were working with basically the same model that was used in the analysis that was published in the Morbidity and Mortality Weekly Report. The difference was that in those early days, we weren't modeling different isolation scenarios. Instead, we were focused on the calibration to the early part of the outbreak, which was, we assumed, before interventions, at least formal interventions, were implemented. And that calibration becomes the starting point for our subsequent scenario modeling, in addition to being informative in and of itself about some of these questions about the potential duration and course of the outbreak so far at that point.
And your very interesting MMWR report, it had two very different scenarios that could unfold with the same beginning case count number. So just knowing the case count really wasn't that informative on its own.
Yeah, so the cumulative count of cases or deaths gives us some insight into the magnitude of what's happened so far, but you're right, that alone doesn't tell us about an outbreak's trajectory or what the future might hold. And there's a number of reasons for that. The biggest and maybe most important one, and that our MMWR highlights, is that a lot depends on the public health measures that happen going forwards. But I think another limitation of a single case count is that it's a single number. And one of the things that, in my experience, is one of the advantages of modeling is it can help us formally think through uncertainty. So in this analysis, we think through a couple different forms of uncertainty. First of all, we use multiple scenarios, not just in terms of number of or level of isolation, but also multiple scenarios in terms of number of deaths. That's another aspect of how the scenarios are defined. And that's meant to emphasize that the true number of deaths is uncertain. We also account for parameter uncertainty. So that is uncertainty about the natural history of the disease, like time from infection to later events like death. Also uncertainty about the reproductive number, how fast the outbreak is spreading. And finally, this is a type of model that we call a stochastic model. And that means that Our simulations involve random chance effects of how many onward infections are caused by each infectious person. And even holding everything else constant in terms of parameters and assumptions about the size of the outbreak, by chance alone, an outbreak may take different courses. And that's especially true early on in an outbreak when it's small, though as outbreaks grow larger and larger, their behavior becomes closer to an average, and we might think about them in a more of a deterministic sort of way.
And in the beginning, when you're putting this together, who's the audience that's requesting it, right? You work for the CDC, so obviously it's a government agency, but who are you modeling for?
I see the audience for this scenario analysis as broadly persons and organizations who are responding to the outbreak. In my experience in the early stages of a situation like this, there's a lot of demand for insights, even approximate ones, about the state of what's happened so far and what future courses might look like, and the factors that might lead us down one course versus another in terms of the size and severity of the outbreak. I think of modeling, especially this analysis, as a tool for enhanced situational awareness that isn't tied to one specific decision. Rather, it's overall adding to understanding of the situation. And I think in that sense serves as one input among many across a range of decisions that various organizations are making about the scale of the response.
Tell me about the process of the modeling itself and the time you had to do this. If it were in academia, and a project like this might take months to put together, but you didn't have that kind of time.
So this did come together quickly. CDC has deep experience responding to Ebola and other viral hemorrhagic fevers, and our response is built on that experience. The kind of real-time quantitative outbreak modeling that we're doing at CDC Center for Forecasting and Outbreak Analytics, which is the part of the agency where I work, represents a relatively new capability within CDC. So the Center for Forecasting and Outbreak Analytics was stood up a few years ago specifically to provide this kind of analytics capacity. And we'd applied earlier versions of this model in other responses over the past year, especially the DRC Ebola outbreak in 2025, as well as the Marburg outbreak in Ethiopia towards the end of last year. So we had that as a starting point to work from. In terms of the timeline, as I first talked about, our initial focus was on the model calibration and developing scenarios. That work happened largely in the last 2 weeks of May, starting just a few days after the outbreak was identified. Then writing and releasing the morbidity and mortality weekly report itself took about a week, but we had the analysis largely settled going into that. So we knew what we had found and what we wanted to say in that report. Timeliness is absolutely critical in an emergency response, and I think that's one of the reasons why we look to tried and true methods like branching process models that are not particularly complicated models and are a well-established approach in infectious disease modeling. So we can try to move quickly with them and get some results.
Well, let's talk about the model itself. And you mentioned it as a branching process model. So explain it like you would explain it to a smart student. Hopefully I can be one of those for this conversation. How does it work?
A branching process starts with a single infection. And in this context, that single infection represents a person who got infected from an animal reservoir rather than person-to-person transmission, rather than being infected from another person. So this is the first person infected in the outbreak. And for that first infection, we simulate how many, if any, people they go on to infect. And this is probabilistic. This is where, as I said earlier, the stochasticity part of the model plays a role. So the way I think about this is imagine rolling a very special die where the different sides are numbered and weighted so that the average number of onward transmissions in this analysis is about 2.5, but the simulated number in any particular instance for a simulated infected and infectious person can vary widely. So oftentimes on this imagined die, the number 0 comes up, and that means that the infectious person goes on to infect 0 other people. But some infectious persons can cause numerous onward infections, and so there's a wide distribution. And this is a common observation in infectious disease epidemiology and dynamics, that a relatively small proportion of infectious persons may cause a disproportionately large amount of onward transmission. So to carry on with the process, if the first simulated infectious person in the branching process causes 0 onward infections, then that's it. The simulation ends. The outbreak consists of just that single infection. But if they cause 1 or more onward infections, then we add however many infections they caused as new people, adding them to the model, adding them to chains of transmission, and we repeat the process, simulating the number of onward infections. Again, imagine rolling that very special die that tells us the number for that particular person, and then adding infected persons to the simulation. I will also note here that we're controlling the time when these events occur. We start at time 0, which is when the first person is infected, and then have distributions to go from time to other events like those onward transmission events, if any. And this process keeps going until either every infected person in a generation causes no onward infection, so all come up as zeros, if you will, which means that the outbreak dies out. That's less and less likely as an outbreak gets larger and larger, or turning to that alternative, as the outbreak grows larger and larger, it begins to exhibit more deterministic exponential growth kind of dynamics. And in the context of the scientific computing, we eventually terminate the simulation at some large size.
You mentioned time 0. How does the model look backwards in time to have a start point?
The model reaches back in time in the sense that all the simulated outbreaks start from a single infection. And this is really where the calibration comes in. So we are simulating these outbreaks, and we're basically identifying the point at which the outbreak gets to a particular number of cumulative deaths. So in our main analysis, that number is 50 deaths, and that we do consider other numbers of deaths given the uncertainty there. So at the point that the curve of cumulative deaths reaches 50 in that example, we set that as being a particular date. Here in this analysis, that's May 24th, 2026. So we basically simulate the outbreak to a given size and then are able to line it up on a timeline with respect to calendar time. So we don't, in the calibration in the first instance, necessarily know, as you say, when was that first infection, but we figure that out based on how long it took to get to a given number of deaths, and that's how we can look back. So the simulated outbreak suggests that it typically takes a few months to go from the first infection to dozens of cumulative deaths, 50 or more. And that reflects a couple things. It reflects the time from infection to death. There are lags here. And the other, maybe even more important thing it reflects is that it would be exceedingly unlikely to get enough cases to have 50 deaths in a single generation of transmission. So you need multiple generations of transmission and the time it takes for multiple generations of transmission to get to an outbreak size that corresponds to 50 deaths.
In the report, you give this headline contrast. If 20% of cases are isolated, so moving into the intervention aspect of this, if 20% of cases are isolated versus 70%, and you're not writing from a point of advocacy, but the headline is helpful from a decision-making context to point out the stark difference in the trajectory of the outbreak depending on the level of isolation.
That's right. And there is a stark difference. We find that if only 20% of cases are isolated starting May 24th, and staying at that level through the next 90 days. That's another important part of how the scenario is defined. And I think we can talk about that some more. And assuming that there are no other interventions, we project a 65% chance of a large outbreak, which we defined as a category with at least 20,000 cases. But if alternatively 70% of cases are isolated, and again, that's maintained at that level of intervention, a large outbreak of that size becomes much less likely. And there's only about a 1 in 20 chance of an outbreak with at least 10,000 cases. So what we see is there are big differences in the distribution of outcomes, but I also think it's important to note that even for a given set of assumptions about level of isolation, the intensity of the intervention and response, that there's still a wide array of outcomes that can happen given all the uncertainties we talked about, whether that's the parameter uncertainty, the stochastic uncertainty. And then, of course, we layer in on this the different numbers of deaths. Those numbers I shared were for the main analysis with an assumed 50 number of deaths as of May 24th.
What's the difference in your mind between this as a prediction versus, I think you wrote about it as a structured argument about what could happen?
I think the distinction we're drawing here between a forecast and a scenario analysis is really critical, not just for understanding what we did here, but it's a key concept for understanding a lot of infectious disease modeling more generally. So I think this is really great to be able to unpack this. A forecast or a prediction formally refers to predictions about what we think will happen in the future. And so we often see infectious disease modelers, including some here at CDC, who work on forecasts and, in a formal sense, predictions about what we think will happen in the future. And those are often over relatively short time horizons, a few weeks ahead. Scenario projections are different. They are conditional statements about the future. They're statements about what we think would happen if an underlying set of assumptions about a particular scenario more or less comes to pass. And as I said, in this analysis, we define scenarios in two different dimensions. In the first, we vary the proportion of patients that get into isolation, but another dimension of scenario analysis is the number of deaths that we assume had occurred cumulatively as of May 24th, 2026. And I think this illustrates that while scenario analyses often do look at different intervention approaches or level of interventions, they don't have to be just that. One can also do scenario analyses that consider scenarios in terms of uncertainty or some other factor about the state of the world that doesn't necessarily have to be an intervention. And something I would add on this is that even if we knew the current level of isolation corresponded to one of the levels we modeled, that still wouldn't turn the scenario projection into a forecast. And the key reason here is that the scenarios, as we define them, have several other assumptions, especially a constant level of isolation from May 24th through the following 90 days. Of course, we know that in the real world, the level of isolation is going to vary over time through a response as resources are deployed and implemented and as the size of the outbreak changes. Assuming a fixed level of isolation is a simplifying assumption that helps us understand the effects of isolation on outbreak dynamics. We're not making a prediction about what level of isolation will be achieved or on what time scale. We're offering these different scenarios, and really in this analysis, and I think many scenario analyses, it can be most instructive to look at the differences between the scenarios in terms of the outcomes that arise rather than focusing on scenarios in isolation.
You mentioned it's conditional, right? And you acknowledge that you can't or you haven't included every possible driver, including behavioral responses and how differences in how people respond to the outbreak could make a big difference in the scenario projections.
That's definitely a possibility. And I think it's good that you mentioned behavioral responses, because I think that of the range of limitations that we identify in this analysis, and that's one of them, I think that is probably one of the more important ones. It's very likely that such changes do occur. I think one of the real challenges from a modeling standpoint is making assessments or assumptions about the extent of those changes, or assuming that they necessarily will occur to a particular degree. I suspect that such changes in terms of prevention measures that individuals take likely vary across outbreaks depending on perception of risk and the extent to which communities have the ability to make some changes that could reduce risk.
And to give a concrete example here, the outbreak in the DRC is unfolding in a context of conflict. And as I've read, high mistrust among the local health system communities, not necessarily believing the cause of the outbreak. And that influences how they respond. But if public health practitioners were more successful on the behavior change front, that could lead to much more isolation.
It could lead to better outcomes, I think, in a number of ways. One is through the formal pathway, if you will, of isolation as a public health intervention. It could also lead to changes in contact rates or other preventive measures that people might take, even aside from formal public health measures like sick persons entering treatment and isolation.
Your sense of where things stand now in the outbreak. We're a few weeks after your initial report. Right now, this is looking like the second largest outbreak on record, potentially headed toward meeting or maybe even surpassing the 2014, 2016 West Africa outbreak. How are things looking?
In this analysis, we framed our outcomes around the cumulative outbreak size by late August. So quantitatively speaking, we can't make a direct comparison between the current cumulative number of cases or deaths and those ranges of cases and deaths that we report in the analysis, because the temporality is an important part of the interpretation. We were looking at that cumulative number at 90 days. We said that over the past month, a great deal of work has gone on in the affected communities to find infected persons and work to get them into care and isolation. And as our analysis shows qualitatively, pushing that proportion of infected persons in isolation makes the worst outcomes less and less likely. So in that sense, I think we can have some cautious optimism about progress that is being made, but there's certainly a lot of uncertainty still about this outbreak and different courses it might take. Of course, it depends on the progress that has already been made and continuing to make more progress. We'll need more time and more data to be able to draw conclusions about the outbreak's trajectory. I think it's quite normal in outbreaks, broadly speaking, that our best understanding of what happened only comes somewhat retrospectively. So there's definitely still a lot of uncertainty as we're very much in the midst of this response.
As you explained, you're part of a team putting together the machinery for these types of analyses in an outbreak like this. This is data science, it's epidemiology, it's very technical work. I know you framed the model as a simple model, but behind the scenes of the model, there's a lot of assumptions and work to get the model calibrated. So I'm curious if we could change gears a little bit to your career trajectory coming out of undergrad and getting a doctorate of science and moving into the public health workforce.
My doctor of science degree is in epidemiology, and I focused on infectious disease, epi, and modeling, in addition to learning about epi and epi methods much more broadly. So right after finishing graduate school in 2019, I joined CDC as part of CDC's Epidemic Intelligence Service, which is a 2-year training fellowship in applied epidemiology. I was a field assignee with the Alaska Division of Public Health in Anchorage, Alaska. I think the hands-on experience of being embedded in a state health department was really valuable for me. I learned a lot about public health surveillance and outbreak response in ways that might be difficult to learn in a classroom or from a textbook. And then in March of 2023, I started with CDC's Center for Forecasting and Outbreak Analytics and have been in this role since then and have had opportunities to work on a number of different infectious diseases and a number of different outbreaks.
So your training ground was COVID.
In large part, yeah. I was a CDC EIS officer through starting before the pandemic, but through much of it.
You are a commissioned officer with the U.S. Public Health Service Commission Corps. Talk a little bit about that.
The Public Health Service Commission Corps is one of the uniformed services of the United States, and we serve in a variety of federal agencies, including CDC in the Department of Health and Human Services, but also beyond the Department of Health and Human Services. So in a wide array of public health roles. Myself, I'm in the scientist career category of the Public Health Service Commission Corps, but we have lots of different people with public health and clinical backgrounds and professions all working together to support public health work and serve vulnerable populations.
And so this is a very applied career trajectory. I was thinking about students who are debating whether to go into epi as a field. There's research epidemiologists who might support academic research studies. They would learn many of the same techniques that I think you use on a day-to-day basis. But what led you to take the more applied route?
I've always been interested in public service, and I think that really attracted me to serving in the US government. And I think we do, as you say, really draw on a lot of the scientific methods and techniques that epidemiologists use broadly, whether they're in applied work or they're in research settings. I think there often are more commonalities than there are differences in terms of trying to understand public health problems and how we can prevent morbidity and mortality and help people live longer, healthier lives.
When you're not modeling an Ebola outbreak, what's the rest of your portfolio look like?
So I work on a variety of things, non-pharmaceutical interventions broadly, worked on questions around duration of isolation for COVID somewhat earlier, worked questions related to the data we get at CDC from hospitals and how that can be used in modeling and forecasting. But I've been on a number of outbreak responses, including the Sudan virus disease response in Uganda last year, and I mentioned Marburg earlier, and now this response.
I wonder if you can say to what extent that generative AI models have come into the type of work that you do. Obviously, in data science and epi, machine learning has been a good part of it for a while, but generative AI being newer, to what extent are you using those models in your work?
This is certainly something that is evolving. One of the ways we use it, probably the primary way I personally have used generative AI models, is in the context of scientific computing. I had to both some developing code itself, but also generative AI as a tool to ask questions about how to do things in scientific computing and build up that knowledge. We do a lot of human review of code, absolutely looking at the code and writing and running tests for our code in a formal sense. I think another aspect of how we validate our work is applying subject matter expertise about infectious disease dynamics to make sure that our results are plausible. There is potentially some use of generative AI, but there's also a great deal of human oversight because ultimately we have to be responsible for what we publish.
Let me ask you then, for students considering this type of career with all the changes that AI is bringing in their education and training, what do you think are the most important skills to be focusing on as an undergraduate and maybe as an early graduate student?
Well, it's certainly not necessary to major in math or statistics or computer science to do infectious disease modeling. And indeed, I didn't major in any of those three things. I would nonetheless encourage students interested in this kind of work to learn as much as they can about math and statistics and to get experience with scientific computing. I think one particular aspect of this field that's very valuable in infectious disease modeling is to have a familiarity with Bayesian approaches, at least at a conceptual level, to thinking about statistics and evidence would be one piece of this.
Thank you for your time to talk through this. I'll be refreshing the CDC and MMWR pages to see updates as the outbreak progresses.
I really appreciate the opportunity to share some about our work. Thank you for having me.